how do we actually put a value on health? I mean, not just feeling good, but quantifying well-being in a way that helps make those really crucial decisions about healthcare funding, interventions, that sort of thing.
Yeah, it's a fundamental question, isn't it?
It really is. So today we're diving deep into the short form 6 dimensions, or the SF-6D.
Right.
At its core, the SF-6D is this smart, generic way to measure health that uses, well, public preferences. It actually emerged from some very widely used health surveys.
Exactly, and its big mission, to generate these things called utility values, which sound technical,
Okay.
but they're key to creating quality-adjusted life years, or QALYs.
QALYs, okay. We hear that term a lot.
And that's exactly right.
Yeah.
This measure of the SF-6D, it isn't just about collecting data points. It's really about understanding how the public prefers different health states,
Yeah.
and using that insight to actually inform the economic evaluations of healthcare interventions.
So it connects the dots, essentially, between someone's personal experience of their health and those big picture policy decisions that, well, affect all of us.
Precisely. It bridges that gap.
So our mission in this deep dive is to trace the SF-6D's pretty fascinating journey. We'll start with its origins, back with the SF-36 survey.
Which many people might know.
Yeah, exactly. Then we'll move through its intricate evolution to the second version, SF-6D v2. We'll explore the really innovative methods behind it, some significant challenges it overcame, and ultimately why it's such a vital tool in healthcare economics today.
Sounds like a plan. You should get ready to gain hopefully, some serious clarity on what can seem like a complex topic.
Definitely hope so. Okay, so the SF-6D, it didn't just appear out of nowhere, right?
No, not at all.
Its story really begins with another measure, the SF-36 Health Survey, and later the shorter one, the SF-12.
Yeah, and these have been incredibly successful tools for measuring health-related quality of life, HRQL, for years now. They capture insights across, 8 key health areas.
Yeah, everything from physical functioning to mental health. Really comprehensive.
But what's really interesting here, the key point, is that while the SF-36 gave you scores for all those individual domains, so you got this rich profile of someone's health,
Right.
it didn't offer a single overarching value, one number that truly captured people's preferences for being in those different health states.
Ah, I see. And that was a gap, especially for economic analysis.
A significant gap. If you're trying to do rigorous economic analyses, comparing different treatments, you need that single preference-based score.
Okay, so let me see if I'm getting this. If you're trying to figure out which healthcare intervention is more effective, especially when cost is a factor, you need a way to combine both how long someone lives and how good that life is, quality-wise.
Exactly.
Is that where QALYs come in, then?
Precisely. QALYs, quality-adjusted life years, are this brilliant metric that combines both the quality and the length of life into just one number. They are absolutely critical for cost-effectiveness analysis, or CEA. They help decision-makers weigh up different options in healthcare. And the SF-6D, well, it was specifically developed to produce these utility values for the QALYs directly from that existing wealth of SF-36 and SF-12 data.
Clever. So using data that was already being collected widely.
Exactly, leveraging that existing resource.
And this whole pretty ambitious project, it was spearheaded by Professor John Brazier at the University of Sheffield.
That's right. Discussions kicked off back in the early 1990s.
Oh, quite a while ago.
Yeah, it started modestly, a small proof of concept study.
Right.
And then it really scaled up in 1999 with funding from Glaxo Wellcome. That allowed them to involve a proper representative sample of the entire UK population.
That's quite an undertaking. So once they had this treasure trove of SF-36 data, the real challenge must have been, okay, how do you distill this detailed survey into a single preference-based score that actually means something? How did they even begin?
It's a careful process. The team had to select a very specific set of items from the SF-36, the first version, that were actually suitable for this kind of valuation task.
Right, not every question would work.
Exactly. They had very clear criteria. First, avoid redundancy. So if 2 questions were basically asking the same thing, they'd pick just one.
Makes sense.
They also preferred items that were negatively phrased, like limited a lot, rather than not limited at all.
Why negatively phrased?
Because those were generally seen as more impactful when you're talking about the goal, which is often reducing negative health impacts. And finally, they looked at which items translated well culturally, for international use.
Okay, practical considerations too, and the result of all that careful selection.
The result was the SF-6D v1 classification system. It eventually used 11 items 8 from the shorter SF-12 version 1, plus 3 extra ones from the full SF-36 version 1.
Okay.
And these questions define 6 core dimensions of health: physical functioning, role limitation, mental health, social functioning, pain, and energy/fatigue.
The 6 dimensions, hence the name SF-6D.
Precisely. And here's the really astonishing part. Combining the levels within these 6 dimensions meant they could describe over 18,000 distinct health states.
18,000. Wow. That's an incredible number of potential health scenarios. But how on earth do you put a utility value on 18,000 different situations?
Yeah, good question. That's where the valuation survey came in. They couldn't possibly value all 18,000 directly, of course.
No, imagine that.
So they chose a carefully selected subset. 49 health states were directly valued using a very clever statistical technique called an orthogonal array to ensure a good spread.
Okay.
And then they added another 200 states through stratified sampling to cover the range. And the primary method they used for this in face-to-face interviews in the UK was something called the standard gamble.
Standard gamble. It sounds a bit like a game show, doesn't it? But it's serious science, right?
It absolutely is serious science, despite the name. Imagine you're a participant in this study. You're asked to choose between 2 options. Option A, living for the rest of your life in a particular health state, let's say. A state with moderate pain and some physical limitations.
Okay.
Option B, taking a gamble. That gamble is between getting full health for the rest of your life or immediate death.
Whoa. High stakes.
Very.
Yeah.
And they'd adjust the probability, the p-value of getting full health in that gamble until you, the participant, were completely indifferent. You couldn't choose between living in that described health state for sure and taking the gamble.
Ah, the point of indifference.
Exactly. And that point of indifference allowed them to place all these health states on a numerical scale where full health is anchored at 1 and immediate death is anchored at 0.
That's a very clever, if slightly unnerving way to elicit preferences. What were some of the early challenges they faced with this?
Well, one significant early hurdle was logical consistency. In the initial models, in some rare cases, you'd find that the model produced utility values that actually increased as the described health state got worse.
Oh, that's not right.
Definitely not logical. So they had to refine the statistical model quite carefully to ensure that monotonicity held that as health got worse, the utility value always decreased, or at least stayed the same.
Okay.
This resulted in the final SF-6D V1 UK values ranging from 0.301 for the very worst health state described by the system.
So still valued above 0, above death.
Right, all the way up to 1 for full health. Importantly, in this initial UK value set, none of the health states were valued as worse than dead. That came later.
Interesting. And once this innovative SF-6D V1 was developed and validated, it became accessible for use.
Yes, licensed jointly by Quality Metric and the University of Sheffield. And crucially, academic and non-commercial use was and is free.
That's important for research. So from its initial launch, the SF-6D wasn't just a static tool. It started evolving almost immediately, adapting to new data sources, embracing new methodological advancements.
That's right. One of the very first adaptations was making it compatible with a shorter SF-12 survey.
Ah, yes, the SF-12.
Exactly. SF-6D V1, SF-12. It could still define, I think, about 7,500 distinct health states. The beauty of this was it allowed researchers to generate utility values from a much briefer questionnaire, which is often practical, without a huge loss of information.
Less burden on the person filling it out.
Precisely. And it also had to adjust later when version 2 of the SF-36 and SF-12 came out. They did that by collapsing some response categories to ensure it remained compatible.
And what if someone missed answering a question? Could the system handle some, incomplete data?
Yeah, that's a great practical point. The design actually allows for some missing data, which is helpful. Crucially, if a missing response wouldn't actually change the overall score for that dimension, because other answers already indicate the most severe level.
Oh, I see.
Then it could often be accounted for. So, for instance, if someone reports they're already limited a lot in bathing and dressing, maybe another question in that physical functioning dimension becomes less critical for defining the severity level of that whole dimension.
Okay, that makes practical sense. This takes us into a really fascinating area, though. How these health states were actually valued statistically. It sounds like the traditional models ran into some issues with the unique nature of this preference data.
That's right. The data you get from these valuation surveys, like Standard Gamble, can be quite skewed, often bunched up at the top end near full health, and it's not perfectly continuous data. This can really challenge traditional statistical approaches like standard regression.
And that matters because,
Well, it raised important questions about how accurately these estimated utility values truly reflected reality, especially maybe for the more severe health states down at the lower end of the scale.
right,
And that's where these things called non-parametric Bayesian approaches started to emerge as a more flexible and arguably more robust alternative.
Bayesian models. Okay, bit more advanced statistically.
Yeah, a bit. But the key thing is they could better capture the complex relationships and the sort of weird distribution within the data without making as many assumptions as the older models. And the impact was significant. For the UK SF-6D V1, applying one of these Bayesian models resulted in average health state value differences of about 0.11 compared to the traditional methods.
0.11, that sounds like quite a difference on a scale of 0 to 1.
It is, and that difference could go up to 0.25, a quarter of the scale, for the very worst health states. So it really mattered for those severe states.
Wow, that's a significant improvement in accuracy, potentially. And it's truly remarkable that this Bayesian approach is so powerful, it can even combine data from different countries.
Absolutely. That's a huge advantage, particularly for countries that might not have the resources to conduct their own massive, expensive valuation studies from scratch. You can leverage data from elsewhere.
That's incredibly valuable.
Definitely. And beyond just this statistical modeling, there was also this broader international shift happening in the preferred valuation techniques themselves.
Ah, moving away from standard gamble.
Increasingly, yes. While many countries initially did mirror the UK's standard gamble approach for their own SF-6D V1 value sets, you saw this in China, Japan, Lebanon, Portugal, Spain, Brazil,
Okay.
criticisms started to grow. Standard gamble can be complex for participants to understand all those probabilities.
Yeah, I can imagine.
And there was this concern that it tended to assign relatively mild, maybe too high values to very poor health states, possibly because people are naturally risk-averse when thinking about death.
Right, they shy away from the gamble.
Exactly. So this led to a rise in alternative methods.
So what really stands out to you about these newer methods that started gaining traction instead?
Well, the discrete choice experiment, or DCE methods, really soared in popularity. They became much more common.
DCE, how does that work, roughly?
In a DCE, instead of the gamble, participants are typically shown pairs of hypothetical health states and simply asked to choose which one they prefer. Or sometimes it's choosing between a health state and staying in their current health. It's generally seen as cognitively easier.
Just choosing between options.
Yeah. And we saw SF-6DV1 value sets developed using DCE in countries like Australia, the Netherlands, and the USA. Other techniques also started appearing, like best-worst scaling, BWS, and time trade-off, TTO.
So a real diversification of methods.
Absolutely. It really highlights this critical evolution in how we try to elicit public preferences, moving towards methods often seen as more straightforward for people to engage with, and potentially giving more robust outputs, especially at the severe end of the health spectrum.
Okay, so given all these advancements, all the lessons learned from SF-6DV1, it makes perfect sense that eventually a completely new version would emerge. Let's talk about SF-6DV2. What was the core motivation driving its creation?
Yeah, despite its huge successes, SF-6DV1 did face some valid critique, as we've touched on, particularly around its classification system, the actual items and response levels, and also the valuation technique.
What were the main issues with the classification?
Well, there was sometimes ambiguity in how the severity levels were ordered, especially within physical functioning. The role dimension, the one about work or daily activities, had what we call a floor effect, meaning lots of people, even those with significant health problems, reported the lowest severity level. So it wasn't very good at distinguishing between people with mild versus moderate role limitations, for example. It lacked sensitivity there.
Ah, okay. Not enough granularity.
Right. Plus, remember the vitality dimension. It was positively framed, lots of energy, unlike all the other dimensions which were negatively framed, like pain or limitations. That could cause confusion for respondents.
Consistency is important.
And then there was the valuation issue we mentioned, the standard gamble, sometimes assigning relatively high values, even for quite severe health states. Again, possibly reducing its sensitivity to capture the full negative impact of really bad health.
Okay, so a number of specific areas for improvement identified.
Exactly. So SF-6DV2, which was published in 2020, was specifically designed to tackle these very issues head-on.
How did they go about improving that classification system then?
Well, they undertook really extensive psychometric analyses using very large data sets. The team identified 6 factors, similar dimensions to SF-6DV1, but with carefully refined item selection and wording.
What were some key changes?
A really key conceptual change was making all the items negatively formulated for consistency, so energy became worn out.
Okay.
They also refined the response levels. Physical functioning went from 6 levels down to 5, removing one ambiguous category. Role limitations actually expanded from 4 levels to 5, with a much clearer rank order of severity, addressing that floor effect,
Better sensitivity there.
hopefully. And the pain dimension was also improved, to focus more precisely on the severity of pain, not just how much it interfered with life. More direct.
That sounds like a monumental effort, really digging into the details to improve precision and clarity. And what about the valuation for SF-6D-V2? Was that also significantly different?
Yes, dramatically different. The UK value set for SF-6DV2, which was published alongside the new classification system, used a comprehensive discrete choice experiment protocol.
Ah, the DCE method.
Right. It involved participants completing 360 different choice tasks. The data were collected online from over 3,000 UK respondents, a big sample.
Okay.
And here's the really surprising fact we hinted at earlier. The resulting SF-6DV2 UK value set now ranges from 1 for the best health all the way down to minus 0.574, the very worst state described by the system.
Minus 0.574, so significantly worse than dead.
Exactly. And critically, based on this valuation, over 15% of all the possible health states defined by SF-6DV2 are now valued by the UK public on average as being worse than dead.
Wow. That is a profound shift from version 1, which had that floor of 0.301. What does that dramatic change actually mean for its practical application?
Well, it means that SF-6DV2 can capture a much wider and arguably more realistic range of the health continuum. It seems to be reflecting those more severe health states and the public's aversion to them, with perhaps greater fidelity than version 1 did.
More sensitivity at the bottom end.
That's the idea.
Right.
And other countries that have adopted this same DCE protocol for SF-6DV2, like Australia and Iran, they're producing similarly wide value ranges, often going into negative territory. And consistently across these countries, the pain dimension shows the largest negative impact on utility values. Pain really drives down perceived quality of life.
That makes intuitive sense. Now, this raises an important practical question. What about a standalone version? If all you need are the utility values for an economic evaluation, do you still have to administer the full long SF-36 or SF-12 survey?
That's a great question. And for a long time with SF-6DV1, the answer was basically yes. But a truly significant game-changing development for SF-6DV2 is the creation of the SF-6DV2 Health Utility Survey, or HUS.
HUS?
Yes. It's a standalone 6-item short form. Just 6 questions, one for each dimension.
Only 6 questions. That's huge.
It's a massive difference. It vastly reduces the response burden on patients and research participants.
Yeah.
Think about busy clinical settings or large surveys. Being able to get a valid utility score from just 6 questions is incredibly valuable.
How did they ensure those 6 questions worked well?
It was very carefully developed. They used methods like think-aloud interviews where people talk through their thought process as they answer to ensure every question was clear, unambiguous, and comprehensible. And it's already been translated into, I think, about 20 languages now.
So it's ready for international use.
It is. And there's even ongoing research looking into whether SF-6DV2 scores can be accurately predicted directly from SF-12 data for situations where you only have SF-12 data available. That's not straightforward currently, but it's an active area.
Okay, so we have these 2 main versions now, SF-6DV1 and SF-6DV2, both having evolved significantly over time. How do decision makers in healthcare or researchers know which one they should use and when?
Yeah, that's a key practical question. The choice often depends, quite simply, on which version of the underlying SF-36 or SF-12 was used to collect the initial health data in a particular study.
Ah, so it's tied to the source data.
Often, yes. If you have data collected using SF-36 version 2, for example, it's generally recommended now to generate SF-6PV2 utilities if you can, especially in countries like the UK where value sets are available for both versions.
Is there work being done to link the 2 versions?
Yes, future research is definitely aiming to develop methods to sort of map scores between SF-6DV1 and SF-6DV2 for better comparability across studies that use different versions. That would be really helpful.
And for new studies?
For new data collection, the standalone SF-6DV2 HUS, the 6-item version, is a fantastic option if minimizing patient burden is a primary concern, which it often is.
Right. And what about international adoption? Are there enough country-specific value sets to make SF-60D widely applicable globally? You mentioned numbers earlier.
Yeah, currently there are more official country-specific value sets available for SF-6DV1. Around 9 countries have their own weights. For SF-6DV2, it's about 5 so far.
So still fewer for the newer version.
For now, yes.
Yeah.
But that number for SF-6DV2 is expected to grow pretty rapidly, because that discrete choice experiment valuation protocol used for SF-6DV2 is much more cost-effective to implement, especially using online surveys compared to the older standard Gamble method.
So it's easier for countries to develop their own V2 value sets now.
Exactly. Lower barrier to entry, you could say.
How do the big health technology assessment agencies, the HTA bodies, or the reimbursement organizations, how do they view the SF-6D in their guidelines? Is it a well-accepted measure?
Oh, absolutely. The SF-6D is frequently cited as a recommended preference-based measure in HTA guidelines around the world. It's seen as a credible tool.
Can you give an example?
Sure. In England and Wales, for NICE guidelines, while the EQ-5D is typically the primary preferred measure,
Right, we hear about EQ-5D a lot too.
the SF-6D is explicitly recognized as a perfectly valid alternative, particularly if there are reasons why the EQ-5D might not be psychometrically suitable for a specific patient group or the condition being studied.
Okay, so it's definitely in the toolkit. This brings us to a really crucial point.
Yeah.
Psychometric validity. How robust is the evidence that the SF-6D actually works reliably? That it measures what it's supposed to measure in different populations?
Yeah, assessing psychometric validity is absolutely paramount, especially because there's no single objective gold standard measurement for something as subjective as health status or people's preferences for health.
Right, you can't just put a ruler to it.
Exactly. So for SF-60V1, there have been quite a few systematic reviews looking at its performance. They generally show strong evidence of validity in specific clinical areas, things like urinary incontinence, visual disorders, depression. It performs well there.
But maybe mixed evidence elsewhere.
Yeah, evidence can be a bit more mixed in other conditions. An interesting finding, though, is that SF-60V1 tends to have fewer ceiling effects compared to the EQ-5D.
Meaning fewer people max out the score.
Right. It seems better at distinguishing between different levels of good or very good health. However, the flip side is that SF-60V1 sometimes showed higher floor effects for more severe conditions.
The problem you mentioned earlier, lots of people scoring at the very bottom.
Exactly, which can limit its ability to distinguish between different levels of extreme severity. If everyone's hitting the floor, you can't see if a treatment makes someone slightly less severely ill, but still very ill.
Okay. And what about the newer SF-6DV2? What's the emerging picture of its validity? Is it addressing some of those issues?
Well, the emerging evidence for SF-6DV2 is looking very promising so far. Studies coming out of countries like China, the UK, Iran are demonstrating its validity both in general populations and also in specific patient groups.
Like which ones?
They've looked at things like Pompe disease, which is a quite rare, lymphoma, breast cancer. And in these studies, SF-6DV2 seems to successfully discriminate between groups that you'd expect to have different health statuses based on their condition severity.
So it can tell the difference between healthier and sicker groups.
Yes, and it's also shown promise in capturing changes over time within individuals, including picking up statistically significant treatment benefits in some clinical trials. So it seems sensitive to change.
That's crucial for measuring treatment effects. So bringing it all together, why should we, or anyone interested in healthcare, care about this intricate measurement system? What's the real-world impact of all this detailed methodology?
Well, I think understanding the SF-6D, its strengths and weaknesses, means understanding how critically important healthcare decisions about which treatments get funded, for example, are informed. They're informed by trying to get a comprehensive view of both the patient experience and the values of the wider public.
It's about the basis for resource allocation.
Exactly. It's about ensuring that the enormous resources we spend on healthcare interventions are allocated based on the most robust, preference-based measure we have of the actual health benefits those interventions provide. It adds rigor to those decisions.
And is there a way to know if a change in the SF-6D score is actually meaningful?
Yes, that's another important aspect. Researchers have worked on estimating minimal important differences, or MIDs, for SF-6DV1.
MIDs.
Yeah, basically, how small a change in the score is actually noticeable or meaningful to a patient. These NID estimates vary depending on the patient group, but they typically range from maybe 0.01 to 0.1 on that 0 to 1 scale.
So it gives you a benchmark for interpreting results.
Precisely. It helps researchers and clinicians understand if a statistically significant change in a trial is actually clinically meaningful for patients. That's incredibly useful for applying these measures in research and potentially in practice.
And for those listening who might actually want to use it in their research or work, how do they get access?
Right. The SF-6D, in all its forms, SF-6D v1, SF-6D v2, and that standalone SF-6D v2 HUS, is licensed by an organization called Quality Metric. As we mentioned, it's generally free for non-commercial academic use, but there's a fee for commercial applications.
Yeah, and the scoring algorithms.
You can typically get the SF-6D scoring algorithms included when you license the underlying SF-36 or SF-12 surveys as well. So it's designed to be quite accessible, especially for the research community.
Okay, good to know. Taking a step back now and connecting this to the broader landscape of health measurement, how does the SF-6D really stack up against other widely used generic health measures out there? We mentioned the EQ-5D. There's also the Health Utilities Index, or HUI.
Yeah, it's a good question because there are several well-established measures. Like those other generic measures, the SF-6D covers those essential core dimensions of health. Things like physical functioning, mental health, pain. They all tend to cover similar ground.
Any unique aspects to the SF-6D's coverage?
Well, one notable inclusion in the SF-6D that isn't directly captured in, say, the most common version of the EQ-5D is the fatigue or vitality dimension. That's quite prominent in SF-6D.
Okay, but they're not interchangeable.
Definitely not. Each of these measures differs in really crucial ways. The exact wording of the questions, the response options they provide, the recall periods they ask about, like today versus the past 4 weeks. And, as we've discussed extensively, the valuation methods used to get the utility scores, and the availability of country-specific value sets. All these things differ.
So you can't just swap one for another and expect the same result.
Absolutely not. While they serve similar overall purposes in economic evaluation, they aren't directly comparable number for number.
What, then, would you say is the unique advantage, the real selling point of the SF-6D in this somewhat crowded field of measures?
I think its greatest strength, arguably, is that direct, elegant link back to the SF-36 and the SF-12 surveys.
The fact it derives from them.
Exactly. Because those two underlying surveys, the SF-36 and SF-12, are incredibly widely used internationally. They're staples in health research and clinical trials. This means there's a colossal existing pool of data already collected using these tools.
Ah, so you can calculate SF-6D scores retrospectively from old studies.
Potentially, yes, if they use the right version of the SF-36 or SF-12. But more importantly, for new studies, it allows researchers to gather this really rich suite of information, all from a single source, a single administration of the survey.
What kind of information?
You get both the detailed profile of a person's health across multiple domains from the full SF-36 or SF-12, and you get that single preference-based utility value from the embedded SF-6D items, all in one go.
So a fuller picture from one questionnaire.
Exactly. It offers potentially a much fuller, more nuanced understanding of the impact of health conditions and interventions than you might get from a measure that only gives you the utility score.
But we touched on this before, having to use the full SF-36 or SF-12 in new studies just to get the SF-6D score. That could still be seen as a burden on respondents, couldn't it? Longer surveys can definitely lead to fatigue and maybe lower quality data.
You're absolutely right, and that was, and sometimes still is, a significant practical concern. Longer measures can definitely lead to respondent fatigue. However, the brilliant development of that standalone SF-6D v2 HUS, the 6-item version, directly addresses this issue for studies that are collecting new data specifically for utility measurement.
So the HUS solves that problem for prospective studies.
It offers a concise, efficient alternative while still leveraging all that robust foundational psychometric and valuation work that went into developing SF-6D v2. It really feels like the best of both worlds in many scenarios now.
That makes sense. The journey we've traced, from SF-6D v1 with its standard Gamble roots to SF-6D v2 using sophisticated DCE and Bayesian modeling, it really showcases how the entire field of health valuation is constantly pushing the boundaries, isn't it? Embracing state-of-the-art methods.
It truly does. You see this evolution, the systematic addressing of criticisms, the continual refinement of how health is actually measured at the item level, and this enthusiastic embrace of new, arguably better, approaches to valuation. It's a field that learns and adapts.
And the international aspect seems key, too.
Absolutely. The ongoing development of more and more international value sets is crucial. It ensures that when healthcare decisions are made in a specific country, they can be informed by preferences that are specific and relevant to that country's unique population and context, not just borrowing values from somewhere else.
It sounds like, despite the competition, the SF-6D is really set to remain a vital tool in the health economists' and health researchers' toolkit for the foreseeable future.
I think that's definitely how it's envisioned. It's expected to remain a cornerstone measure internationally, primarily, yes, for cost-utility analysis supporting HTA
Yeah.
decisions, but also increasingly for vital applications in routine clinical settings, perhaps for monitoring patient progress, and certainly for broader population health assessment and tracking health trends over time. Its adaptability and the ongoing innovation behind it really ensure its continued relevance.
So we've just traveled quite a distance, haven't we? From the very specific questions on a health survey like the SF-36, all the way to the complex, sometimes controversial, but world-shaping landscape of QALYs and economic evaluation in healthcare.
Yeah, quite a journey.
And it's all thanks, really, to the ingenious design and the continuous responsive evolution of this measure, the SF-6D. It's a powerful example, I think, of how nuanced, preference-based measurement can profoundly impact those huge, real-world healthcare decisions that affect, well, all of us.
It really does highlight how something that can seem quite abstract, this concept of health utility, is actually deeply grounded in the lived experiences and the expressed preferences of ordinary people. And it's not static. It's this constant process of refinement, always aiming for greater accuracy and better real-world applicability in how we, as a society, value health.
So what does this all mean for you listening right now? Maybe consider this. The next time you read about a new, expensive drug being approved, or perhaps a particular healthcare service being funded, or maybe even cut,
Hmm.
think about the subtle yet incredibly powerful influence of these underlying measurement systems working away in the background. The choice of a single question's wording, or whether a standard gamble versus a discrete choice experiment was used years ago to value different health states.
Yeah.
These seemingly small methodological details can profoundly shift how we collectively understand and ultimately decide upon the true value of an intervention that's designed simply to improve someone's health.
It's the science behind the value judgment.
Exactly. Something
Okay.
to definitely think about.